Good morning. I would like to thank the organizing committee for the honorable invitation. I will start from the point where Dr. Zelos actually ended his speech. I will try to exhibit that maybe one or 2 ports less could make a difference. So it's not an easy topic, and this is not because there is not a substantial amount of literature. Actually, the uniportal VATS history begins in the in the beginning of our century. It was initially adopted for minor thoracic procedures. I think that the term was coined by Dr. Rocco, who actually published a description of a technique for wedge resections. The technique remained in oblivion for pretty much until 2010, when González Rivas conducted his first uniportal lobectomy. Of course, the technique was met with a lot of skepticism in the beginning, and a lot of questions was raised about safety and reproducibility, not to mention about any advantages. So from this perspective, I would actually claim that it's an evolution of previous minimally invasive techniques, rather than, as many would claim, a revolution. Although it may have revolutionized the way we treat our patients. Now, the uniportal VATS technique is a well-established minimally invasive technique with a broad spectrum of indications. It is used for pulmonary resections, from the simplest to the most complex ones, for resection of mediastinal tumors, for diaphragmatic surgery, and even for esophageal surgery. The intercostal uniportal VATS technique, because there is also the subxiphoid uniportal VATS technique and the transcervical uniportal VATS technique. So the intercostal one, it's actually an anterior approach technique, which means that we approach the aspects of the hilum from their anterior aspect. It usually involves a 3 to 5 centimeters incision at the level of the mid-axillary line, or even more anteriorly. From this level, convenient access is offered to the fissure, to the hilar structures, and to the posterior mediastinum for lymph node dissection. Although it can be done with conventional instruments, if you use specially designed instruments, which are long, thin-shafted, double articulated and curved, you may experience a lot more convenience, which may be translated in less surgical time. Usually a 30-degree, 10-millimeter camera is used. For the mediastinal masses, we usually make an incision in the third or fourth intercostal space. If the tumor is located in the anterior mediastinum, the patient is slightly inclined anteriorly, and if it is located in the anterior mediastinum, the patient is slightly inclined posteriorly. The subxiphoid uniportal VATS, it involves a usually transverse incision or a vertical incision in the subxiphoid area. The access to the thoracic cavities is gained bluntly. Upon entering the chest, the costophrenic fat is removed. The patient is placed in the supine position if mediastinal tumors are addressed, or in a full lateral decubitus position with some inclination maybe posteriorly if lung procedures are to be done. The technique is very promising, especially in terms of pain, as it has already exhibited very clear advantages even over intercostal uniportal VATS. However, I will not refer to it because it is still not so widely spread, probably due to its complexity. Its main disadvantages are the fact that, especially in the left side, you have the heart obstructing your field and intervening with your maneuvers, and because it is quite difficult with this technique to do a complete lymph node dissection, especially for station 7. So when we speak about advantages and disadvantages, we should ask about for who? For the patient, for the doctor, or for the discipline itself. And we should also refer in these particular fields, pain, length of stay, duration of chest drain, lymph node dissection. This particular one is very important as it is used to document surgical oncological efficacy, operating time, blood loss, morbidity, mortality, conversion rate, and of course survival. And of course, advantages compared to what? I will not refer to advantages over open surgery because these are well documented. Uniportal VATS, after all, is a minimally accessed technique, so it has all the advantages of the other minimal access techniques. So those who have adopted it claim that it offers a better visualization of the operative field, as it preserves in a better manner the depth. There are some geometrical explanations about this, but most of them, the rationale behind it is that it actually mimics open surgery, where our eyes are above our hands. So placing the camera in uniportal VATS in the uppermost part of the incision, actually surgeons claim that this mimics the natural way we view things. Others say that with uniportal VATS, a surgeon can easily prepare himself for other surgical concepts like nodes and emerging robotic technologies. Another potential advantage could be that when you fail with uniportal VATS, you can convert to multiport, whereas you fail with multiport, you may have converted to open. But most of these advantages are quite subjective. They're quite subjective. Opinions can differ. So we have to look into the numbers in order to document any advantages in the other fields. This is a recent meta-analysis published in the Journal of Thoracic Disease. It included 11 studies from 2013 to 2016. 7 of them were retrospective and 4 of them were propensity were match studies. The quality of data provided was very good. So this meta-analysis claimed a significant advantage of uniportal VATS over multiport techniques in terms of pain in in postoperative day 1. Although this advantage remained till postoperative day 3, it was not so significantly statistically significant. In terms of length of stay, again, it seems that the UniVATS technique is more advantageous compared to its to the multi-VATS techniques. As you can see in the forest plot, almost all the studies included favor the uniportal technique. Chest drain duration, again, significant advantages demonstrated for the UniVATS technique. In terms of duration of operation, there seems to be not any significant difference. UniVATS has an advantage, but this is not significant. Intraoperative bleeding, again, some studies favor the UniVATS, others the multi-VATS, but as the meta-analysis showed, there could be a significant advantage of the UniVATS technique. This is very important. Here in the area of lymph nodes harvested, the multi-VATS and the UniVATS actually score equally. Both of them yield a high number of lymph nodes, so the oncological efficacy could be argued that is equal. And this is very important because it actually may bring back down the matter to a matter of access rather than a matter of better treatment or not, as far as long-term outcomes are concerned. Conversion rate, again, both of the techniques exhibit very low conversion rates. UniVATS seems to have an advantage, but it is not significant. Overall morbidity, for some reason, it seems that reducing the accesses down to one port seems to have a significant advantage. So the meta-analysis demonstrated a significant advantage of the UniVATS over the multi-VATS in this particular field. In conclusion, the meta-analysis demonstrated a significant advantage of the UniVATS in terms of pain, postoperative day 1, in terms of length of stay, chest drain duration, intraoperative bleeding, and overall morbidity. These are two other meta-analyses. They were published before the one I just mentioned, quite recent, both of them. Pretty much they say the same things, but this is not quite exciting, surprising, as many of the studies included were also the studies included in the meta-analysis I just mentioned. It's also quite noticeable to say that most of the papers included, they come from China, probably because of the ultra-high volume and the number of the centers that have adopted the techniques. This is a recent meta-analysis published a few months ago. The one I just mentioned actually addresses the matter in terms, in the context of lobectomies and septectomies for non-small cell lung cancer. This meta-analysis includes 39 studies, and it addresses major, minor thoracic procedures for the lung, for the mediastinum, even for the esophagus. The quality of the data is quite high. Pretty much as the previous meta-analysis, this one actually favors UniVATS over multi-VATS in the fields of chest tube duration, blood loss, length of stay, and pain in day 1. However, there are no differences are documented in the field of complication, operative time, and of course, lymph node dissection. This is a study comparing the two techniques in the context of mediastinal surgery. It is a matched study, so the quality of the data is good. There seems to be a difference in the operative time, in postoperative pain in day 1 and in the discharge day, and in the length of stay. However, the intraoperative blood loss and the consumption of the analgesics postoperative seems to exhibit no difference. This is a randomized study, it was published quite recently. It comes from Spain. The authors randomized 106 patients which were treated for lobectomy, with lobectomy for non-small cell lung cancer in 2 groups. Group A, 51 patients. The patients were treated with UniVATS and the rest of them with multi-VATS. The study found no difference in any of the fields we mentioned, not pain or chest duration or length of stay or 30-day mortality. So the authors concluded that the outcomes of uniportal VATS are not superior to those of the multiport VATS. This is a best evidence topic. It addresses the issue. 8 papers were used. 2 studies addressed the lobectomy and 6 of them minor thoracic procedures. Again, the authors of this topic, although they concluded that although there is a clear advantage in terms of pain, in terms of the other fields, there is no significant advantage favoring the one or the other technique. The disadvantages, again, I would say they are quite subjective, as they may depend on the level of expertise of the surgeon. So some claim that stuffing a single incision with the instruments and the camera could produce a lot of interference between the surgeon and his assistant, which could result in the increase in the duration of the operation, even in the safety of it. Sometimes, especially if the estimation of the incision is not well estimated, inconvenient angles could come up. Another issue is that the camera, there is no port for the camera, so the assistant actually keeps the camera suspended through the whole time of the operation, and this could produce a lot of fatigue for him, which could impair his performance during the surgery. Again, I state these are not subjective, these are not objective, these are quite objective disadvantages. To conclude, there seems to be a clear advantage in terms of postoperative pain favoring the uniportal VATS technique. And also there are improved outcomes, again favoring the uniportal VATS technique in as far as chest drain duration is concerned and length of stay. It is important to state that both techniques are equally efficient as far as the oncologic outcome is concerned, although there are not long-term outcomes and long-term comparisons still available, at least to my knowledge. It is, and this efficacy can be actually documented by the efficacy in the lymph node dissection. We should actually decide, is it a matter of access and surgeon's preference? It is certainly not a different treatment for lung cancer. And we should try to evaluate the outcomes, and we should try to compare actually long-term and significant outcomes like survival and recurrence. Thank you very much.